members of the public would like to submit a question in future, they'll be able to do this by 12 noon on the Friday before the board meeting, which then follows on the Wednesday. And we have a number of members of the public signed to join us and attend today's meeting. And as I said, this is the first time that Thames Valley Board has met in public. The ICB was established on the 1st of April. A meeting was held to appoint the board members, agree the committee structures and terms of reference, and agree the constitution, scheme of reservation and delegation, and a number of key policies which all underpin how the organisation operates and makes decisions. The government's documents that I have mentioned are all available on the Thames Valley ICB website. Thank you to everyone for attending. Do we have any conflicts of interest or declarations of any interest relating to today's agenda?
Can I just flag, and I know we mentioned this earlier, the conflict of interest register has a few issues with transferring slightly out of date data across from some legacy organisations. So I just wanted to flag that mine is broadly accurate, but it's got one in there that I no longer hold, and I took off the online system and I made a few other updates. So I will work with the team just to make sure that they're updated, but there's nothing here relevant to today.
Thank you very much, Ilona. And we will all recheck declarations of interest. There is a transition from one system to another, and just make sure that what's been brought across is accurate and continues to be so. We have the minutes, please, of the joint committee of the Bob and Frimley ICBs, which was held on the 10th of March. Could I have questions, amendments? And if not, if no comments about accuracy, could I please have a board approval? Thank you very much. I'm now going to hand over to our CEO, Dr. Nick Broughton. Thank you.
Right, Priya, thank you. Good afternoon, everyone. In the pack today, there's a copy of my report and the Chief Officer's report. A couple of things to add to that. Firstly, as many colleagues will be aware, last week a new Secretary of State for Health and Social Care was appointed, with James Murray succeeding Wes Streeting, and in addition, Preet Kaur Gill was appointed as Under Secretary of State in the department, succeeding Zubir Ahmed. I think what's clear from conversations we've had over the last week or so is that there will be no change in direction in terms of the NHS England plan and the development of the target operating model, and indeed the focus for this year, building on the work of last year and some of the improvements we saw across the health sector, particularly in relation to financial performance and operational delivery. Just picking up what Priya said earlier regarding the creation of the new Thames Valley ICB, in order to create the new organisation, we established the Transition Programme Board, which met for the last time on the 17th of April. And in the pack today, there is a copy of the closed-down report produced by that board, which is chaired by Ilona and one of our former non-executives from Bob, Sims-Gadasa. There have been some changes to the executive team, which I'd like to highlight. Firstly, Sandra Grant, who was the Chief People Officer for the Integrated Care Board, has now been seconded on a full-time basis for the remainder of this financial year to the NHS England South East Regional Team. And in addition, at the end of next week, Matthew Tate will be leaving the organisation. Matthew has been as the Executive Delivery Officer for the organisation, and prior to that was the Chief Delivery Officer for the Bob Integrated Care Board, and has worked in the system since it was created. And I'd like to put on record my thanks, and I think the thanks to the wider board, to Matthew for all he's done during his time with us. I think that's all I really wanted to flag. I'll take the rest of the board as read, and very happy to take questions.
Thank you very much. Comments or questions in relation to any of the issues in CEO's report? Thank you. Let's move then to the case for change and strategic objectives. Over to Hannah Iqbal. Thank you, Hannah.
Thank you, Priya. So whenever you set up a new organisation, it's always good to know what the organisation is here for. So this document sets out the purpose of the ICB, what we're here for in terms of our strategic objectives, and what's the case for change that underpins why those are our strategic objectives. So in the pack, you'll see a slide deck of data. This is a data pack that we went through in our first board development session as the new Thames Valley ICB board, and really kind of sat with this data and pondered it, given that this is the context that we're now responsible for stewarding the healthcare budget for. And so when we look at that data, it tells us many important things. It tells us about the needs of our population today, how those needs will change over time. We see that we have issues of an ageing population, rising complexity of need, rising long-term conditions, and inequalities of outcome and access and experience. And so what we've started to then think about is what's actually modifiable here, what should we focus on, and if we were going to be looking back in a few years' time at the work of this ICB, what would we want to be known for? And so that takes you to the strategic objectives. And we've thought about these in kind of two ways. There's the objectives of all ICBs, which are to improve outcomes, reduce inequalities, and ensure access to consistently high quality care. But also, I think we've had a debate this morning about if we're really going to shift the dial on population health strategy, we've got to be quite targeted about the things that really will drive impact. So we talk in the paper about 3 population health interventions. The first is around using the data capability we have. How can we optimise the offer for each segment of our population and move from thinking just about universality of provision, but more bespoke provision that meets needs and also crucially doesn't have a kind of over-layering and cluttering of pathways. We know we have multiple offers for our population. For example, if you take our frail residents, and that can be difficult for them to navigate, but it's also not cost effective. So how do we get more specific about our offer for each of our cohorts? How do we enact early and slow the progression of ill health and make sure we scale what works? And how do we recognise that actually, if we just stare at this data and we think about what we know, what are we missing? So how do we target hidden need? How do we work with colleagues from local authorities and public health around this table to think about the wider determinants of health, and also where the data story doesn't tell the full story. So this now is the frame for the organisation. It will be the frame for the metrics we track, for our objectives at executive and employee level across the organisation, and really for how we hold ourselves to account for impact. So looking for approval of these today. Thank you.
Thank you very much. Let me open this up then for comments and questions.
I'll chip in. Just to say, delighted that we have this in front of us fairly early on in our life as an organisation, because it helps frame a lot of the operation of the business, but also the governance that shapes that for us. So a big thank you to me, and it was really good to have the earlier conversation as a board when we were just beginning to set these out in April. So a big thank you, and I'm very supportive of them. Thank you. Tim?
I'm Tim Nolan. I'm a non-exec member, independent non-exec member, and I'm also a resident of Buckinghamshire. I'd say, just to echo Alona's comments, I think it's an excellent document. I know a lot of hard work has gone into it. I think very importantly, a lot of consultation and a lot of very wide level of engagement is undertaken. This is not being created by a small group of people in a darkened room. It's the exact opposite, in fact. And so I think that makes it all the more powerful. I think the other really important point about, well, 2 important points. One is the fact it's data driven. We're trying to take wherever we can the emotion out of this and any bias or historical viewpoints individuals may have, and base this on facts and realities of what's actually happening in our population and with our residents. And secondly, the most important thing of all is that it's forward looking, not backward looking. It's looking at how we can prevent health issues in the first place, how we can improve the population health by prevention rather than just relying on cure. And that is absolutely the way forward for the organisation and all our partners. So hugely supportive.
Thank you, Tim. And Martin.
Thanks, Chair. So for those publics, Martin Reeves, local authority partner member here and Chief Executive Officer County Council. What he said, but But seriously, I think we should acknowledge that the evidence-based data under which our strategic intent is set is a great starting point, but it's only a starting point. The rich picture is not as complete as it could and should be, but work's already underway. But I think I should shout out, and we should say this as a board, that the intent to think about prevention, asset-based approaches to health and well-being across our great area is absolutely the focus, alongside getting all the rest of the system absolutely optimum. And I think that's a great starting point, and we should hold ourselves to account to make sure we continue to keep that as a priority and a focus for us as a board.
Thank you.
Thank you. Just want to change tack slightly to public involvement and communications around this work as well. Firstly, there is a really important story to tell here to our population around methodology which underpins this, and then how it changes the decisions that we will take around allocating over £5 billion of public money on how healthcare is spent as a result of that. And we need to really get that crisp, but in a way that people can understand the population, because it speaks to the heart of what it is we're here to do. So I completely agree with you, Hannah. The second point is perhaps, again, slightly different. The strength of this data is derived from the fact that it's bottom up. Every patient, every resident in our geography is an individual with their own segmentation in this process. And actually, when one of our residents accesses our services, whether it's in a GP practice or in one of our hospitals, their segment is available for their clinicians to see in front of them, and could change the care in which they receive in a positive way, because it means that we take different decisions to meet their requirements. As a tangent, my parents live in this geography, and my mum rang me up one day and she said, "I've just found out that I'm a red-rated patient on my segment. What does this mean? Like, am I about to die?" It's like, no, actually, quite the opposite. It means that we understand you've got some complex needs, and we're going to support the care that you need. So there is something really important around how we communicate that back to people, because the simple language of red and amber and green doesn't really deal with the nuance of what it actually means to have a segment and the care that you receive as a result of that. So we'll give some thought from a comms team perspective around how we could do better in communicating what this means for people.
That is so helpful and important, isn't it? I was speaking to some of our community researchers, and so they are very embedded in our neighbourhoods and very much sort of gaining insight directly from people. And we were looking at the segmentation data for the Thames Valley, and the first, without going into any explanation of what that meant, the first thing was, which of these colours would you like to be? And it was such a uniting moment of conversation. And so the behavioural change that we will want to make in ourselves and see in our populations will all be dependent on wanting to make that change too, and understanding how we can do that. And as Martin says, the richness of the data that we could have is going to be much greater as we work more across the system. So I think it's a very good place to start. And the conversation that we have constantly is about how we apply the Thames Valley pound to buy the best outcomes for the population, and that money then gets moved around because it can buy different outcomes. And I think that's a really important element of the work that we'll do based on this. So I have Nick and then George, please.
Yeah, and my question is probably for George and Hugh, and it relates to the slide in relation to changing QOF condition cohorts. And some of the terminology used in that. And are we bound by this? Because I suppose I'm just surprised that some of the groupings are sort of imprecise. So mental health, for example.
Yeah, so I'm George Gabber, I'm partner member for primary care. So yeah, I mean, they really are set at national level, and they're within the actual GP GMS contracts. So the groups within QOF are set. I think one of the things that's really important, and I think is thinking about, okay, so these are groups, but we can look at other groups. We don't. So, for example, in the neighbourhood work in Buckinghamshire, the QOF frailty metric has generally been around EFI historically. It's not quite there now, but that's what it was a few years ago. Whereas actually, we're now using the PNG red rating to identify cohorts. We can use our own cohorts. I think the other bit to think about with QOF as well is that actually there are opportunities for us as strategic commissioners to build on what QOF does. So as an example, we know in Buckinghamshire we've seen a reduction in SMI health checks over the last year, still above the target, but a reduction from where the baseline was. And actually I suspect that a large proportion of that was due to the removal of one of the QOF targets, MH021, which was around doing 6-in-1 health checks for people with significant mental illness. As well as the withdrawal of our own Bob LCS for SMI health checks at the same time. So I think what we need to do is QOF is useful as a national tool, but we can build on that as a system around where our strategic priorities are, and I don't think we have to be limited by what the QOF targets are. I think we can look at our own system targets to meet those priorities.
And I should have said at the outset, QOF is an acronym for Quality Outcomes Rating.
Yes.
Thank you. And Sajid.
Yeah, Sajid Khan, independent non-exec. So I think the other point just to reinforce is how diverse the Thames Valley footprint is. And, we have a lot of deprivation in the big towns, but to reinforce, we also have a lot of opportunities and challenges in the rural areas. Just to reinforce Martin's point, Oxford is a marmot region, and they have done a lot of work and research into things like rural health challenges. So I think whatever our set of things that we need to, Hannah, to focus on, one of those areas is going to be looking at how we kind of, like you said, not apply a universal approach. We've got to apply a very targeted approach, but we've got to kind of make sure we understand that all of our patch, not just kind of the areas that attract the most attention. The second point is that the data is really, really important. We're seeing, I don't know if everyone else is getting the WhatsApp messages about taking yourself out of the NHS data sharing system because of certain technology providers at the moment. I think there is a big challenge just on even in sharing the data we have today. We know we have to go beyond that because the wider determinants of health do require other data sets. And I do note that the new recent Secretary of State does have a housing background in his CV. So I'm hoping between that and some of his other statements around digital improvement that we can actually start to address not just the treatment side of this, but the broader sense of it.
Thank you. I think that's been really helpful to see this set out so clearly at this stage, and there is so much opportunity for, because as you say, this data really paints the picture of the individual resident and the individual patient, rather than a pathway, a disease process, an organisational delivery, etc. So it's so important for us as our North Star, as our key information. We are asked then as a board to endorse the approach outlined and specifically to approve the strategic objectives for adoption as set out in the paper.
Great.
Thank you. I think we have a not just agree, but a really strongly and passionate agree, which is a very good position to be starting in. Thank you very much. Shall we move now then to our Chief Nursing Officer, Sarah Bellers, please, for our quality report.
Thank you, Priya. So you have the report in front of you. I wanted to just mention, in addition to the report, the Wokingham Send inspection, which I couldn't put into the report because it was only published on Monday and we weren't allowed to share it before then. The Wokingham Send inspection was not as we would have hoped, and there were 3 areas for priority action for the local area. One of the actions included the wheelchair service that the ICB commissioned. Now the board will and has been cited for a number of months about the wheelchair service and the remedial actions that we've taken since the SEND inspection in February. We haven't waited for the publication of the report. I will share with the board the SEND inspection following the meeting, but I just wanted to raise that as that wasn't included within the papers. And I'm happy to take questions.
Thank you very much, Sarah, and thank you for updating us in relation to that SEND inspection, and as you say, a matter that has been a topic of discussion at board. May I ask for comments and questions, please? Martin?
Yeah, just briefly on the SEND inspection, it's important for the notes just to recognise it as an area from a position that none of us wanted to be in with regards to the provision for those youngsters at most vulnerability with regards to special education needs and disability, to move to a position not just with the improvement notice from Department for Education to be lifted to the area, but actually to now be recognised as national best practice. But also at the same time to note there is so much still for us to do as a system together. But I think there's a time for our families, for professionals, a number of people in our system between health, the local authority, to actually recognise that vast improvement. You can turn around services, you can improve outcomes if you remain focused as leaders, and to recognise though that the journey genuinely now with the most significant shift in policy and legislation nationally with regards to SEND and schools and the health of those youngsters needs to be recognised, that we've got a great platform to work from now as an area, but a lot still to do.
Thank you. Sajid and then Caroline, please.
So just a question for you, Sarah. There's a lot of reporting that a lot of the complaints now are AI generated and almost becoming quasi-legal. What impact is that having? And obviously there's also some evidence that trusts are responding with AI. So I don't know, it's your AI talking to my AI, but effectively, are we seeing a lot more kind of these longer type complaints with a lot more, kind of legal implications? And then a question for you, Sam, in terms of OPIC and the screening programme, do you see additional efficiencies that can apply to kind of getting these rates up as kind of as it starts to kind of the commissioning starts to get more at the local level?
So thank you, Sajid. So yes, we have seen an increase in AI generated complaints. I think what's really important to understand that that even if an NHS organisation uses AI to generate a final complaint response, the investigation into the response, into the actual complaint is completed by human beings, and the analysis of that is done. When they tend to do it, tend to be like that. The AI generated complaints it's making things really difficult, because actually what people are putting into AI isn't necessarily what they're complaining about, and AI will give an answer that it thinks they want rather than what they're actually asking. So quite often we're finding we're not answering the what people are trying to complain about as a result. I think that we are looking in the new way of working with complaints when we implement the structure, to have a much more responsive team that talks to people at the beginning of the complaint process to try and understand it, to try and reduce some of this confusion, because a lot of work goes into a complaint response, and if it isn't actually the complaint that someone wants to make, that's really unhelpful.
So if I could pick up the point on screening and IMS, thank you, Sajid. It's a really important one. So it is subject to passage of the health bill as we understand it today, going through Parliament over the course of the year ahead. But if it was to pass as it currently is constituted, the responsibility for the commissioning of screening and immunisations would move from NHS England, where they're currently held, to the ICB. And this is said in no way to be critical of the really good work that NHS England have done in this space, which has been excellent over the years. There is a case to be made for the opportunity of that responsibility being held more locally by an organisation such as this one, which is closer to its local population and has data like we've seen today in our previous session around, which shows us where our inequalities are and where our opportunities are to make the greatest impact on local population health. So I'm really looking forward to the opportunity of working with the board, with our public health partners such as Sarah's around the table, to see what we can do in this space, because it is actually one of the most effective weapons that we have around tackling inequalities and improving health overall. So it's a really big opportunity for us.
Caroline Corrigan, I'm Chief People Officer and cover Corporate Affairs. Sarah, there's been a highly publicised meningitis outbreak. I wondered if you wanted to just reflect on that and the role of the ICB in that outbreak.
I think it's been widely reported, and there are four cases that we are aware of. Sadly, we're really sad to report that one of the cases died, and our thoughts are with their family and friends. We have managed a fantastic response with the support of local providers to track and trace the people and to give them the prophylaxis. We had a huge uptake, far greater than we usually get in these circumstances, which is a credit to Oxford Health. Actually, they were the organisation that did the following up of them and the thing, and they're currently vaccinating as we speak.
Thank you. Sorry, did you want to come in on that?
Yeah,
Yes.
thanks. And just following up on that, there's also wider system engagement with UK Health Security Agency and communicating closely with schools where necessary as well, just to ensure that residents and parents are kept up to speed with accurate information.
Thank you. Tim.
Thanks, Priya. Yeah, Tim Nolan again, independent member. Just on the continuing on the screening vaccination theme, in your report, Sarah, it makes brief reference to the COVID vaccination, which is great that it started off in spring 26, and my 90-year-old father's already had his jab, which is great. So that's good news. He's in the patch. But specifically, it mentions that we've got some good mitigations in place to address gaps. But it then says where GPs are not signed up to the programme. Could you just elaborate? I mean, I know we've got a couple of our GP colleagues in the room as well. What does that mean when it says GPs are not signed up to the programme, and what lies behind that? Just I'm thinking from a public perspective, really.
So I think an example of that would be going in and doing the care home vaccination. So many of the practices across the system support us by going into nursing and care homes and vaccinating individuals. Not all practices that support care homes are able to do that, and therefore we have to then commission a different way of doing it. And often it's another practice that does do it that will support us.
Yeah, so it's not that there are GP practices in the area that don't do COVID jabs in general.
I think that in the majority of the cases, the primary care has been fantastically supportive of our effort in order to vaccinate across the board.
Thanks.
Thank you. And then,
Yeah, Sarah, thanks for the report. I suppose just to flag, sort of the greatest health inequalities are experienced by those with a learning disability. And therefore, we note the update in relation to the LEADER programme, LEADER standing for Learning from the Lives and Deaths of People with a Learning Disability. I think it's important for this board to be conscious of our responsibilities in ICB in relation to the LEADER programme. And obviously, it's not just about undertaking the reviews, it's about ensuring that the learning from those reviews is then embedded in the services that we commission and the services provided by the providers across our system. So just to flag that, so I think it's something that will rightly attract increasing political attention moving forward, not least because we have been struggling to improve life expectancy for people with learning disability who typically still die 20 years before the general population.
thank you, Nick. And any other, I don't think I can see any hands on screens. Any other comments or questions? No. Thank you very much, Sarah. And our next item is questions from the public. We have no questions from the public today, so I'm going to give us a little time if there are any other items of business that anybody else would like to raise. I'm just going to look round both the screen and the table, and I'm getting no. Thank you very much. Thank you again to all the work that has gone into the setting out of the case for change and the strategic objectives, the driving force for the work that the ICB will lead and convene on for this period. So thank you to that, and thanks for everybody who's attended and joined us in the public.
Thank you.
Thanks all.